Good evening, ladies and gentlemen. Welcome to you all on behalf of Canon Medical Systems, and thank you for making time to join our webinar on the use of AI solutions in clinical practice. My name is Wolter de Graaf, and I am MRI clinical scientist at Canon Medical Systems Europe. This evening, we have some very interesting speakers that will talk about the practical benefits of deep learning reconstruction on the Vantage Elan NX edition. Professor Aliprandi and Professor Tomczak will explain how they use the advanced intelligent clear IQ engine, AiCE in short, in their daily routine in various anatomies, both for higher resolution as well as for reduced scan time. These experts will show how they apply it individually or in combination with other acquisition techniques. First, however, I would like to spend 2 minutes on explaining this new technique that is currently available on the whole product portfolio of Canon MRI systems. AiCE, see through the noise as we call it. It's the world's first deep learning reconstruction for MR. If we quickly look into the artificial intelligence workflow for MR, in this case, we start with raw MR data, which is being reconstructed by an engine into an MR image. The radiologist reads this MR image and forms a radiologic report with help of post-processing software. Computers help nowadays a lot with computer-assisted detection or diagnosis, and this is a domain where most AI companies currently are operating. However, we are going to look here at deep learning reconstruction. This is a technique that takes the raw MR data and tries to transform it in as good as possible MR image. We try to improve the image quality by using this deep learning reconstruction. This is the AiCE engine. How does it work? At the factory, we train the machine using low SNR images and compare it with high SNR images and ask the computer to differentiate between signal and noise in these images. Once these settings have been optimized, it's going to the operational phase where the MR system in the clinic is acquiring data. We apply these found settings through a very strong engine, a computer, using a deep convolutional neural network. This then results in the high SNR images we are going to see. For the last 40 years, our conventional filters for everybody was a little bit of a non-optimal solution. However, it was the best we had. So if we compare an original image and we apply a filter, you will see that the noise has been reduced, but also it has become a little bit blurry. And if we do a subtraction, in fact, you see what we have lost. In here, I still see a brain, which is in fact a loss because I might not only see a brain, I might also lose pathological features. This new technique, AiCE, when we apply here on the original image, the AiCE technique, you see that the noise is gone. The image is preserved, it is still sharp. And if you look at the subtraction, you will see that here we only throw away noise and a little bit of Gibbs ringing. This is the advantage of AiCE. A quick example here, on 1.5 Tesla acquired, 2 times 15 seconds breath hold. You see what happened when we just acquired it, and you see here what happens when we apply the AiCE technique. Another slide from the same sample. Here you see the images of the kidneys, and here you see how clean they have come out. There is always a trade-off in MR between SNR, scan time, and resolution. The technique we're using here is AiCE, where we try to reduce the noise to improve our SNR. Normally, when you gain SNR, you can use it to reduce your scan time or to increase your resolution, but you have to pay on one side. Now with the AiCE technique, we can use both at the same time, so it gives you more flexibility. You can have high resolution imaging, you can do faster imaging, and you can apply it to all body regions. So with that, I would like to start over to our first speaker, which is Professor Aliprandi. He's the head of MSK imaging at Bernasconi Radiology Center in Seregno, Italy, and he's president of the MSK section of the Italian Society of Radiology. Next to that, he is head of the radiology service at the Zucchi Clinical Institutes in Monza and collaborates at the La Badonina nursing home and also holds a number of academic functions. He will talk together with 2 of his assistant radiologists, Dr. Porta and Dr. Carapella, on a study they performed on the performance of AI in MSK MRI and compared it to conventional imaging. And now, Professor Aliprandi, I would like to invite you to share your screen and guide us through the outcomes of your study, Evaluation of Deep Learning Reconstruction in MSK Pathologies.
Thank you, Walter. And good evening from Italy. My report is evaluation of deep learning reconstruction MR imaging, denoising of MSK system, a pilot study. First of all, I would like to thank Canon for this collaboration, which gave us the opportunity to try and work with a new product based on deep learning reconstruction. I would also like to thank Dr. Bernasconi and its collaborators for the data acquisition, the images provided, and the collaboration. AiCE is a novel iterative reconstruction technique based on deep learning, which permits to improve the signal-noise ratio, resulting in shortened acquisition time and higher resolution, thus giving much detail to our images. Working every day with data quality images is not only a pleasure to the eyes, but also sometimes it helps you reaching the correct diagnosis. For example, in this project on density image of knee, we can observe a horizontal complete posterior on tier of medial meniscus with a perfect delineation of a small meniscal cyst, not so easily recognizable with the standard MR images. So, purpose of our study was to evaluate the diagnostic performance of advanced intelligence clear IQ engine reconstruction in MSK MRI compared to the original protocol. We retrospectively evaluated MR imaging of all patients who underwent MRI examination of MSK system with AiCE control acquisition at Bernasconi Radiology Center in comparison with the standard protocol. Patients without comparable images, 3D isotropic images, or images with any other filter applied were excluded. Finally, we included 35 patients divided into 10 knees, 7 shoulders, 9 hips, and 8 ankles, with a total of 14 dB FATSAT, 14 T1 weighted, and 5 ACE T2 weighted, with or without fat saturation. According to the literature, we qualitatively assessed the anatomical structure of the joints, meniscus, tendon, fibrocartilage, ligaments, bone, and age. Each anatomical structure was rated based on the appearance as follows. Anatomical structure is not visible, anatomical structure only partially visible, anatomical structure fully visible with substantial blurring of borders, anatomical structure fully visible with slight blurring border, and finally 5 point for excellent delineation of anatomical structure. This is a sagittal proton density FATSAT image of knee. We can observe an osteochondral lesion of medial condyle. In the right image, we can observe the better definition of cartilage thickness and age. We can see excellent representation of the meniscal profile in both images. The white arrow highlights slight spongious edema, less evident in the left image. So, in this case, we assessed 5 points to bone marrow in AiCE image and 4 points to the standard one, and 4 points to the cartilage in AiCE image and 3 points to the standard one. This is another sagittal T1 image of knee. The evidence of the optimal spatial resolution of the new protocol is well reported. In particular, in the right image, the yellow arrows show the clearly definition of the meniscal tear and the high contrast with overlying cartilage, while on the left the difference is not so evident. Furthermore, in right image with the AiCE, the black arrow show a tibial spongious edema area that's in the old standard protocol not so easily visible. In this case, we assessed the 5 point bone marrow edema and compared to 3 points for the old protocol. Other example, ankle sagittal T1 morphologic sequence. However, I suppose that we are agree if I say that we are in presence of two excellent images of ankle. Moreover, in this patient, the AiCE imaging, the highlights are the excellent calcaneus trabecular design, the excellent Achilles tendon profile, the higher subtalar chondral resolution, and the better interface chondral of posterior facet of subtalar joint. The calcaneus circles show the higher resolution of plantar calcaneocuboid and cuboidal-navicular ligaments fibers. On this image, we can appreciate the high quality of both images. The supraspinatus tendon calcification on right imaging is more defined. The articular tendon side is optimal in both images. Furthermore, we rated the same resolution for bursitis and the bursal side tendon erosion. Finally, the myotendinous ganglion, green arrow, the labrum and profile glenohumeral chondral interface has been considered higher in AiCE protocol. Another sagittal coronal facet for the shoulder. We can see the better resolution of the bursal side of a supraspinatus tendon, and in particular, the red arrow is better visualization of the residual fibers of the tendon. Furthermore, the same resolution for bursitis and side tendon erosion is the same. The yellow arrows show the best matched definition of the articular tendon profile in AiCE control and the subacromial bursitis bone marrow edema. Finally, the cartilage interface as better highlighted. Lastly, in this T1 pelvis image, we can observe the improvement of quality imaging and better muscle design and excellent age, and we can recognize every single group of fiber compared to the standard protocol. Secondly, in a large image, we can observe in yellow circle the hamstring tendon and AiCE. Respect to the original protocol, the AiCE imaging as possible easily distinguish the tendinous component of the hamstring from each other and respect to the tuberosity, cortical tuberosity. In this histogram, we summarize the improvement of new protocol over the standard. The most significant difference were found in pelvis and shoulder, particularly in the sharpness of tendon cartilage and interfaces as seen in the images previously shown. We can observe also the excellent inter-observer agreement among the more expert reader and the two readers resident, who reads image in consensus, suggesting that the improvement in quality is recognized by both more and less experienced readers. As explained at the beginning, when we discussed the study design, we obtained a scan time reduction when using AiCE, and this time reduction percentage is shown in the graph on the left-hand side if we look at the orange bar. However, in many cases, not only the scan time was reduced, also the resolution was increased compared to the original scan. As a result of a smaller voxel side, the SNR is dropping. So AiCE needs to compensate for the lower SNR because of the higher scan speed and for the reduced SNR because the higher resolution. That means two factors were changed. So we calculated the loss in SNR because of voxel side difference and corrected with that information the scan duration that should have been used for the original scan. This is shown in the graph on the right-hand side. Before moving to the hand, I show you two cases. This is my patient, a case of follow-up of bilateral hip surgical treatment in femoroacetabular impingement. The image was produced in the Bernasconi Center. In the right imaging, we have a recent examination with AiCE control, and in the left image show MRI original protocol with the standard algorithm. This is the same patient in the axial DPE facet. In the yellow circle, we can see the different representation of the chondral surface, and in enlarged images is more evident higher chondral edge definition in AiCE acquisition respect to the original protocol. In left image, the cartilage is poor visible. Final example, these images were acquired by Canon with the same sequences, but the one on left was reconstructed in a standard way, and the one on the right imaging using AiCE. The right imaging confirmed the air signal to noise, the sharp cartilage and tendonage, and tissue interface definition of AiCE technology. Please note this sequence was acquired at 2 millimeters and 0.3 for 0.3 millimeters in a scan time that is a typical achievable only at 3 Tesla for this resolution. To conclude, score of clarity of visualization of anatomical structure were higher for AiCE protocol compared to those for the standard sequences. Although that was not our primary goal. We obtain also decreased in the acquisition time and of course increased spatial resolution. One limitation of this study is its retrospective nature, that is obviously because we were assessing the broad applicability of this new technology. In the future, we are thinking of designing study to assess AiCE in specific clinical or sport medicine environment. Furthermore, the number of patients we included was 35. It will grow, and as we move along with the evaluation, what we'll do next is twofold. Firstly, we want to evaluate AiCE further to see what it can deliver behind clinical routine. For example, we are working on the 3 submillimetric isotropic sequence to replace the 3 perpendicular planes. And secondly, we are evaluating the combination of AiCE with a new acceleration technique like compress speeder, a method based on compress sense. We have the data already, but we haven't finished the evaluation, although we can see and we have the high expectation of the result. And now I conclude. Thank you for your attention.
Thank you, Professor. That was very insightful. Then our second speaker is Professor Tomczak from Bad Friedrichshall, Germany. He is acting as Executive Director of the Center of Radiology in Bad Friedrichshall and 3 additional sites being Leingarten, Kreilsheim and Heidenheim. Besides his specialization in radiology, he holds qualifications in medical informatics, emergency medicine and medical quality management. Where the previous speaker focused on MSK imaging, Professor Tomczak will also show other body areas and talk about the implementation of the technique in the clinic. The title of his talk is Artificial Intelligence Tool AiCE for MRI. Is it ready for the daily routine? Professor Tomczak, may I invite you to share your screen?
Okay, I think everybody is seeing what are the slides.
Correct.
Thank you very much, Mr. de Graaf, for the introduction. Thank you very much, Canon, for the possibility to get experiences with AiCE. And thank you very much, Mr. Roder from Canon, for helping me with the slides. The purpose of this talk is a little bit more practical. I want to show you what you can do with a word like deep learning reconstruction in the daily routine in a private practice or in a normal practice. What are we wanting for our patients? We want to have high image quality. High image quality means high resolution and high contrast. We want to have fast exams because we want to do a lot of patients per day, and fast exams are the same like optimal economical outcome for the people who are using this MRI. The purpose of the talk is to explain what is the role of artificial intelligence in a practical setting. We have Canon Vantage Elan, which is for which we get AiCE to optimize workflow. And the current experiences I'm talking about are from November 2020 until now. Just a little bit about signal-to-noise ratio and time. Good images require long scan times. You can see here there's an image which is a little bit noisy. It's one acquisition and it's 1 minute 45 seconds. If you would want to have more less noise and more signal, you have to use in a normal setting 10 acquisitions, and the time is going up to 16 minutes 59 seconds, which is way too long for normal practice. To show you the dependencies of signal-to-noise, speed and resolution, you can see here on this graphics. If you have a high resolution, you have and you have a high speed of imaging, you have less signal-to-noise ratio, also the noise is going up. If you have high resolution and you have less speed, you have better signal-to-noise. What we want to have is a high resolution at a high speed and a high signal-to-noise. Most imaging techniques in MRI, which are accelerating the image procedure, are relying on reducing phase encoding steps. Normally, you have a frequency encoding axis, which you can get fast, and you have a slow phase encoding axis. There are several methods which are well known since many years to accelerate the imaging. For example, you can make half-hour imaging, which means you sample a little bit more than 50% of the case space, and you can reconstruct the other missing informations. Or you can use parallel imaging. Parallel imaging means you use several coils to look on one pixel, and you use these informations to speed up your system. Or another thing which I'm talking about today too is compressed sensing. Compressed sensing is well known since, I guess, 2016, and it's the same like compressed speeder, which is named by Canon. So this is compressed speeder from Canon. Compressed speeder means we have a strong acceleration. Besides AiCE, you can combine it with AiCE. It's up to 4 times faster. It's not really depending on coil configuration. It's anatomy independent. It's orientation independent. And you have a speed. You can speed up an image like this here, upper ankle joint from 2 minutes 20 to 53 seconds, and the images are pretty much comparable. So I think they are diagnostic for daily diagnostic use. AiCE is another method. Mr. de Graaf told you how AiCE is working. AiCE improves the signal-to-noise ratio without adding time because it's done after the imaging. It compensates signal-to-noise loss due to fast imaging, so you can use fast sequences with a not so good signal-to-noise ratio, and you can compensate this signal-to-noise ratio through AiCE. It allows on one time a higher resolution by an equal scan time, or identical resolution by a same scan time. Accelerating is independent of channels, so you don't have to have a high edge MRI. So it's working with, for example, the Elan as well. It's for all anatomies and most sequences because it's done on a computer behind the MRI. About the technical development, it's working on a deep convolutional neural network. This is all done by Canon. Show you, and it's there's a training phase for every system. They give thousands or millions of pictures into the system to train it. These pictures have low signal to noise and pictures with high signal to noise, and the system, the AiCE, is learning to differentiate signal and noise, and to create from a low signal to noise picture a high signal-to-noise picture, what we want to have. After that is done at the fabrics or at Canon in Japan. The package is shipped to, for example, Germany, to us, and there's a phase of clinical implementation. So several people of Canon are in your practice, check out how it works in the practice, and you have possibility to personalize the systems to your belongings. Another example for high signal to noise. If you look at these images, you have an XLT2 standard imaging, 0.9 in plane resolution, 4 millimeter slice thickness, and you use 248. This is at all images the same, 248, 2 minutes, 48 seconds. If you make it with if you increase the resolution from 0.9 to 0.6 in plane resolution of the voxel, there's the same time, but the image is becoming much more noisy. You can see this easily here. And if you do it with AiCE, the same stuff, in 2 minutes 48, at the same in plane resolution, you have relatively clear and good delineated images of the neurocranium. Another example, standard imaging, flare sequence, which is a inversion recovery, fluid attenuated sequence, you know that all. In a standard imaging procedure, it's 3 minutes 40, same resolution. With AiCE is 140. So it's more than 50% of the time. Or you can use it to increase the resolution of your imaging or the clarity of your imaging. Here's a standard imaging with 0.15 millimeter, which is really narrow. And if you do that with AiCE, you get really a good looking image, which is much better than the standard imaging. An example of a pelvic standard imaging, 3 minutes 59, same resolution, and with AiCE you can bring it up to or bring it down to 1 minute 19, which is terrible fast. It's a multi-step evaluation. Engineering is done, development of the algorithm. I did show you that in the other slides, verification of the optimal training parameters and implementation in clinical routine. You see here some example imagings. AiCE is applicable to about 96% of all MRI protocols, so that means to everything. Another example of cervical spine, where the comparison between standard imaging with a software version 4.5 and an AiCE imaging, and you see you can reduce the scan time for 4 sequences. In Germany, we do almost 4 sequences because of regulations. You can decrease that to minus 8 minutes at the same image quality. If you're buying the system from Canon, several people from Canon are coming to the site and check your current workflow, and then you can personalize AiCE to your belongings. So you can say, I want to have it so or so, and so on. This needs about, I would say, for most protocols, about 1 week. You can work at this time, and it's an ongoing process. So all the time, new protocols are involved until everything is done. I want to show you some radiology images. For here, an example for proton density coronary fats at shoulder without AiCE and one with AiCE. And in my opinion, you may see it different or same way. Is the AiCE image, even if it's much quicker, has the same image quality. Another example for wrist an axial wrist T2 and an axial wrist T2 with AiCE. Pretty much the same quality, in my opinion. I'm going now to several regions to show you there's no comparison between AiCE and not AiCE. It's all AiCE images from now on. I want to show you just what you can do with AiCE and what images you will get if you use AiCE. This is, for example, normal anatomy of the brain, and you see a sagittal T1 duration 2 minutes and an axial T2 147, which is pretty good. Patient with a subcortical arteriosclerotic encephalopathy or Binswanger's disease. You see here several white matter lesions, not so much. It's in the beginning, so to say, but image quality is good. Duration a little bit over 2 minutes. Another example, I think it's the same patient, where you can see diffusion-weighted images with a p-value of 1000, relatively good in-plane resolution. Duration of such a sequence, 30 seconds. Examples for pituitary gland, it's a different word, pituitary gland. It's a normal anatomy, and you see scan times T1, 141, sagittal T1 with a higher resolution, 257, and 240 for a T2 image, 242. Another patient, a patient with multiple sclerosis, you see these typical paraventricular white matter lesions, and you see duration for an axial flare, 3 minutes, duration for coronary T2, 120 minutes. Same patient, an active lesion, you see here a T1 image with contrast media, the lesion enhances contrast media. It's going up in signal intensity. This is T2 shine through, and this means this is a positive diffusion-weighted imaging. You see early restriction of the lesion in the diffusion as a sign of its activeness. The same patient in MPRH with this T1 3D with contrast media, where you can see this lesion in front of the ventricle. Were pretty much good, pretty good, and you can reconstruct in every direction you want. You can do MPR, and the duration to get such images is 3 minutes 42. Another patient with the inner ear. This is Siemens called a CIS sequence. I think, yeah, it's pretty much the same. And you see high resolution of the inner ear of the vestibulocochlear nerve, for example, in 250 seconds. 2 minutes, 50 seconds, 56 seconds, sorry. Another image of a cervical spine. There you can see an oncovertebral osteopathy of the cervical spine, and see pretty much good delineated. Everything done in 3 minutes. And see here post-traumatic myelopathy. Cervical spine with a disc prolapse. I see you can get a saturity to in a little bit over 1 minute. You can get a higher resolution in 134. No, sorry, no high resolution. It's a T1. Same resolution in 134. And if you make a stir with fat saturation, you need 233. I go a little bit faster over the images. I mean, you are not interested in the diseases, but much more in the time. This is actual T2 duration for several levels, a little bit more than 3 minutes. Another example for oncovertebral arthropathy of the cervical spine. A left convex scoliosis of the lumbar spine, spondylosis. You see here a little kidney cyst. You can get these images in 2 minutes 46, and it's diagnostic. It's clearly really sharp. So this is a severe spondylosis of the lumbar spine. You see an older fracture of vertebral body 11 of the thoracic spine. And you see here several big protrusions and kyphoplasty in this fractured vertebral body. Another example of one of these protrusions. You can see you can get 5 levels in a lumbar spine in 3 minutes. An interesting case, unfortunately not very seldom. This is a patient with on one hand side he has a severe spondylosis of his whole lumbar spine. On the other side he was a smoker and he has a bronchocarcinoma and he has metastases in vertebral body THL12 and in alliance. You see, you get here a T2 imaging in a little bit over 1 minute. It's clearly diagnostic. And here a T1 in 128. The same patient, metastasis of lung cancer, coronal 246. In plane resolution, always very good. And the same patient, 5 levels in 3 minutes as an example for disk space imaging in the lumbar spine. I'm changing to a little bit to the abdomen, some images of the abdomen. You see here a patient with on both sides kidney congestion due to a pelvic mass. And here another interesting patient was a cholecystitis with perifocal infiltrations. You see this here. I'll show you more slides of this patient. And he has a stone in the gallbladder duct. Another images where you see here the stone. You see here the gallbladder duct, and you see that it's there is a infiltration around this, like you see here. It's a big cholecystitis. Then DVE imaging, diffusion weighted imaging at a B value of 800. Really good images in my opinion. High in plane resolution, duration 4 minutes 10. Okay, I am coming to the last slides. This is an example of a female pelvis. On one side, on the right side, you see a simple ovarian cyst. On the other side, you see a hemorrhagic cyst of an endometriosis. Same thing in sagittal, duration of such a sagittal image in the pelvis, 2 minutes, 1:08. Okay, I want to a little bit talk about the economics. If you have per day 13 hours of scan time, we are, for example, scanning from 7 a.m. to 8 p.m. You have 780 minutes per day for all the exams, and if you divide it through 20 minutes, you get the number of patients you can do in 1 day. That means you can do, if it's really going good, you can do 39 patients per day. If you have AiCE, you can the scan time reduce by approximately 30%. That means instead of 15 minutes scan time, you have now 10.5 minutes scan time. Means the changeover is pretty much the same. This is logical. You have up to 8 patients more per day. It's a strong technical component and it's easy to apply. The outcome, or what is the conclusion of this talk, is you can get better images in the same time, or you can get the same images in a much shorter scan time, or you can mix it up a little bit. You can do it like you want. Short story, which is true to the end. Since April, we have the Elan since approximately 11 months. And since April, we have a brand new Canon Orion without AiCE. The same techs are working with the Elan NX and the Orion. We're working on both machines by day. They're changing by day. After a couple of weeks, I asked the techs which were working on the Orion, what do you think of the Orion in comparison of the Elan? And the answer was, the Orion is a great machine. So you have it's better usable for patients which have a higher weight, and you have more channels and stuff like this. Yeah, many good features. But can we have AiCE on it? It's the Elan NX is faster than the Orion without AiCE. That means once you have it, you don't want to miss it. Thank you, and have a nice evening.
Thank you, Professor Tomczak, for this presentation. I think it's time now to look into a number of questions. I got quite some list here. I'm going to distribute a little bit between the two speakers and the people going to answer them. I think you've seen two parts of presentations. One is really showing that it's a sound conclusion to say that you can improve your image quality and your speed, and also the practical implementation of a system like this in the real clinical practice. So I think these two talks could be really complementary. However, I saw there are a number of questions. So the first question I would like to ask to Dr. Porta and Dr. Carapella. Could you maybe elaborate a little bit on the inclusion criteria for your patients? How did you come to choose which patients to include in the study or which ones to exclude?
Hello, everyone. This is Dr. Carapella. Can you see me, please? Yeah, okay.
Yes.
The text randomly shows the patients without selecting the pathology or the ideal patient in order to make the evaluation more objective. And the results are a real expression of the daily life workflow. So we did not select anything, and we just observe what we can do in a real life daily routine.
Okay, thank you. And could you also tell a little bit about then the inter-observer agreement you found when you analyzed these images? Because
yes, of
there
course.
was a clear trend.
We believe that the minimum spread in the evaluations among the experienced observer and the two blinded youngest residents expresses a clear objectivity of the results, because it shows that experience does not influence the final evaluation.
Okay, thank you. And I have another question coming from Mr. Bogomolov, if I say correctly. And he's asking, did you collect another sequence with AiCE, or did you just apply AiCE technology to the previously collected images?
Well, it is AiCE. It was applied on the scan, so it is a different sequence, a different acquisition, and not only reconstructed later. So, in fact, that's why also we obtained different scan times, so a reduction in the acquisition time of AiCE sequences compared to the old ones.
Thank you. I have another question from Mr. and Mrs. Zakaric from Bremen, stating that you've shown great joint images from Italy. How did you get the amount of signal sufficient? It looks like, how did you get a signal while the signal was not there? It's a mathematical algorithm. Where did you miraculously get the signal? I think you have to answer with regard to SNR ratios. Or should I look? I think I can answer if you want, no problem. But
I think this is a technical.
Yeah, okay. Yeah, what we're looking for is the signal to noise ratio. So signal divided by noise. We do not increase the signal, but we reduce the noise. So the ratio number will become bigger. In that way, your image becomes more clear because the background with noise goes away. And in that respect, I think these images have been acquired like they are. Then the acquisition technique has been applied on it, removing the noise, getting you the image quality that was achieved. So it is not anything changed with scan time with that regard. It was the same scan, but then increased. And now I have a question for both presenters. So I think I have to turn to Professor Tomczak. Well, I think he answered it already a little bit, but how much would you estimate your gain in terms of number of patients per day thanks to AiCE and CS? In terms of an economical point of view, what does that represent? So I think you can maybe elaborate a little bit more on it.
Yeah, I think the scanning is much faster. The changeover times are pretty much the same. So if you have an older person, it's a longer time. But I think you can 8 to 10 patients more per day. Is my opinion, because you accelerate the sequences up to 30%, sometimes more.
Okay. And then to Professor Aliprandi's team, could you maybe answer this question as well? What do you think in practice?
In practice, we think that we can improve of up to 20% the patients, but we still have to apply it in the daily practice. Of course, we can also improve the diagnosis. And please keep in mind that Canon also provides the compress speeder technology, and compress speeder and AiCE can be applied in the same scan. So I agree with Dr. Tomczak, and we are going to look at the results in the second phase of our study.
Thank you. So I think you nicely also answered another question by Mr. TCNM here. Yes, it can combine with AiCE and the compress speeder. And as we might have seen from Professor Tomczak's story, there was a slide showing that for 96% of all acquisitions, this technique can be used. Then I think there are a few a little bit technical questions. I think I have to take them in this case. Can the AiCE protocol be installed on all Canon MRI devices, or does it require special hardware? There are a number of systems that can be installed on, of course, the newest ones without problem. However, like you might have seen in the beginning of Professor Tomczak's story, there is a deep convolutional neural network computer running in the back, which is a very powerful computer running on very powerful GPU cards. This is doing the real trick behind it. Yeah, that's computational intensive, and that means you need the special hardware as well. And it's doing a great job. You don't see it in practice, but you only see the outcome. So yes, there is extra hardware needed to make that happen. And then I can combine with the other question about which software version is available with the AiCE. From version 6 onwards, you will have it. Most important, I think, is then also if you want to upgrade, you have to upgrade, of course, to a software version that can handle it. However, it started on the 3T, it's now on the 1.5, it's now also on the Elan. And I like to hear that Dr. Tomczak said, people with the Orion system and the Elan in the house, they can see the difference here. Then there's another question. I think it's also interesting to ask to both parties, both from Germany and Italy. How was the impact after using AiCE to radiographers? Do they like it? I'm thinking of motion artifacts when scan time is longer and we have to repeat sequences. Could you maybe elaborate a little bit on the effects that you see? Maybe Professor Tomczak?
The radiographers are happy with the system because they don't have to wait so long until a sequence is over. So they have, with the standard sequences, they have long times where they can do nothing. And they are sitting and waiting until the sequence is done. And with AiCE, they just pretty much accelerated. And they like that. That's the question. That's the story I told you about the radiographers was true. That's what they like at the Elan with AiCE right now and what they miss at the Orion. So, but I mean, the Orion is, for the Orion is AiCE available as well.
Okay, they do not get overworked now?
No, not really.
Okay. Porta Carapella, could you elaborate on that?
Yeah, we really like the images with the AiCE technology. And about the artifacts, we think that reducing the scan time can provide less artifacts. Of course, you can still have motion artifacts that we did not evaluate in our study, but please keep in mind that there are some filters that can help to reduce the artifacts.
Okay, I understand. Are there other people who still have questions that we could ask to our speakers here in this case? I have, well, one more question then, if there are no other questions are coming in, and that's a little bit about what do you really think about the value of the diagnosis? You choose to say, let's try and evaluate this technique. Of course, that's also a little bit scary. What am I getting in my house and what am I doing with it? So pure diagnostically, what do you think will be the outcome, let's say, in a number of months?
Well, I think that we can obtain both gain of time and a higher resolution. So you have to find a balance between resolution and scan time. Obviously.
Okay. That's what I saw as well was coming in the next study you're going to perform. And Professor Tomczak, you like it as well for the same reason, for diagnostically as well?
Yeah, it's pretty much the same for diagnostic. So this is image quality is the same and speed is going up.
Okay. I see a little bit coming in at the moment. In general, there is a question saying, would radiologists prefer using it for higher resolution or to gain time? Yeah, and I have to add maybe to it, or both. What is the biggest effect that you appreciate?
Yes, we appreciate, of course. And we like
resolution or time. What's for you the most important reason?
Well, we like both. As Marcus said, we have to find the good balance between resolution and time. We do not choose one for the other.
Okay. Thank you. Then I'll see if from Mr. Stutki, what's the fastest value you recommend to use with CS combined at AiCE to have good images? Ooh, I think this might be a very technical question. What's the fastest value you recommend to use with CS? I'm not sure if you're referring to an acceleration factor here, because then it would become maybe a very technical question. Maybe speakers understand better than I do in this question.
Maybe that's a technical question. Maybe you can answer better than us.
So then I like to answer, that's something you optimize together with the application specialists on site to say, okay, this is what I appreciate in the image. Like Professor Tomczak said as well, they're going to sit with you, optimize all the settings with regard for, and now it becomes technical, acceleration factors, regularization factors, AiCE adjust. And I can imagine that maybe in the beginning you're a bit nervous and say, well, just try a little bit. And after 3 months you say, I fully trust this sequence and I fully trust this technique. Let's use everything we have, go for the highest factors that are there. But I can also imagine that it might take a little bit of time. If then there are no more other questions coming in, then I would like to end this webinar. Of course, in case you have other questions with regard to the presentations or about the technique, of course, you can ask your local representative or us, and then we can make sure we answer for you correctly. Therefore, on behalf of Canon Medical Systems, I would like to thank our speakers, our co-workers, the people in the hospitals, but also my colleagues who help people out. And of course, I would like to thank you, your attendance for this evening, and I wish you a pleasant evening or rest of your day. I hope to see you at one of our other webinars, and please check our website, also the one that I'm sharing together now with you, to make sure you don't miss them. Thank you so much, and goodbye.